They don't cry more than normal kids. They don't have behavioral disturbances. Some of them have little temperament issues, but usually not significant. They sleep fine. They react normally. They're normal. So you could tell the mothers the babies are going to come out normal. Well, what about babies that do this longer? Now, you'll see some babies that'll do this, they're still doing it 6, 7 months. These babies maybe not quite so normal. You know, they're more likely to have what we would call regulatory issues, difficulties in controlling themselves and how they react to things in their environment. You know, some of them the ADHD kids, and some of them just abnormal behavioral things, just being difficult kids. My brother's kid reminds me of these. They just kind of are. He's only got 1.5 years left, and he gets out. Some of these kids have a little more trouble. So if you've got one of those, doesn't mean there's anything pathological going on. It just means that he may be difficult. So here's the problem. It's a problem for the parents. It's not a problem for the baby. Baby's going to be fine. The parents may not be so fine. And there have been a number of studies that have shown that this kind of this excessively crying baby can disrupt the family and harm the relationship, and lead to relationship problems and divorce and stress within the relationship. And that's where I think we as pediatric gastroenterologists or pediatricians, and I think probably more the job of the pediatricians, we kind of have to look for these things and be aware of these, because this is one thing we can do, is to try to help alleviate these kinds of problems with the family. I mean, you try to look, how can you help? You can't make the baby quit crying, but maybe you can prevent the parents from having a disruptive marriage or something like that. And I kind of like this little vicious circle diagram here, because it sort of describes what's going on with these kids. The baby cries because he needs something. The crying increases the anxiety of the mother because she doesn't know why the baby's crying. So then she becomes more anxious. The baby perceives the anxiety. What's wrong with my mother? Why can't I fix this? What's wrong? And the baby cries more. And then the mother gets more anxious, and her anxiety increases, and she gets tired and run down because they can't sleep. The parent, they'll come in and say, "My God, I can't get any sleep. This baby cries all night." I don't know how many times you've all heard that, and I'm sure you've heard that many times. And any kind of stress that's in the family is going to feed into this, and this whole situation is creating more and more stress, and this is disrupting the family, and it puts the baby at risk for shaken baby syndrome. And so the one thing that I would suggest that you do in this environment is to look and see if there isn't something that you can do to make sure there's somebody's not going to hurt this baby. Have you ever thought about it? Do you think there's a risk going on? Is anybody in the family going to harm this baby? So, the bottom line is, for the baby, not so much a problem if you look at the abnormal crying during the first 3 months. Colic is self-limited. Most of the time it goes away by 4 months. Usually no long-term ill effects. Occasionally a little difficult temperament that might persist a bit. But the real risk is the tired parents, the anxiety. I love that statement yesterday about how the lawyer or the physician or somebody who's usually in control, and this baby's got them totally wiped out because they're not in control anymore. That kind of a stress situation in the family makes the parents tired, anxious, and the risk then comes to the baby. So that's, I think, what we need to, as pediatricians, look for is the marriage going to hold? Is the relationship going to hold? And is somebody going to hurt the baby? The baby's going to be fine. So only a fit mother can help her infant You got to help the mom de-stress and understand before she can take care of the baby. She can't take care of the baby if she's stressed out and anxious, and that's, I think, the intervention that can happen with most of these. So, what more normally happens with these babies? And I like to say that there's always a reflex action that I see with pediatricians when they see fussy babies, and I want to talk a little bit about that. Because we're physicians, and at least in the United States, I think a pediatrician has 6 minutes with a patient, and that's all the time you got. What I just told you to do takes maybe 20 minutes, and you can't do that 20 minutes in 6 minutes. So how can I get this baby out of here? And I got to do something. And so the first reflex is this. Start the baby on a PPI or an H2 receptor antagonist. Now, I was around in the 70s when everything that was wrong with a baby started to be attributed to gastroesophageal reflux. And there were a few colleagues who I won't mention by name who I think did a lot of harm to our specialty by over-diagnosing and over-treating gastroesophageal reflux. And this trend just skyrocketed throughout the world, and every baby who spit up was thought to be abnormal. So what is reflux? Reflux is when the lower esophageal sphincter intermittently relaxes. There's a little muscle in here, and when you swallow, it opens up, and then it closes, and it doesn't open up again until you swallow again, and so forth. But if you look at that little sphincter, that little valve, it sort of undergoes little gradual relaxations and contractions all the time. And if the baby's intragastric pressure is greater than the pressure inside the sphincter, stuff is going to come up. So you think about this, well, why would the thing be engineered like this? Well, one reason is if the baby happens to get overfed, it's going to reflux and regurgitate and get rid of it. So, that might explain part of why it does that. This unfortunately persists into adulthood, and there's some of us that when we get old, we have to take these drugs because we have heartburn or esophageal discomfort all the time. And if you've ever been pregnant, you probably remember how much things hurt when you ate because you had gastroesophageal reflux, because interestingly enough, the placental hormones will actually cause relaxation of the lower esophageal sphincter. They always, the obstetrician will always say, well, the baby pushes on the stomach. No, there's actually hormonal relaxation of the sphincter during pregnancy. So this is an issue, and because we as adults experience discomfort when we reflux, we naturally assume that the baby is going to also experience discomfort when it refluxes. Well, it turns out that doesn't happen. So I like this study. There's been several studies sort of similar to this one. This one by Susan Orenstein was I think the first one. And Susan took a bunch of babies that were fussy and crying and irritable, and put them either on a potent proton pump inhibitor, lansoprazole, or a placebo. And basically what she showed is that there was no difference in how much the baby cried, and no difference in how much the baby spit, and no difference in the baby's feeding difficulties on lansoprazole or off lansoprazole. The placebo group was the same. So these babies were totally unresponsive to acid suppression. Now, there was something that was significant. Anybody know what it was? Probably, well, Neil knows what it was. Anyway, what it was the babies that got the lansoprazole had more infections. Why did they have more infections? Both gastrointestinal and respiratory, because the function of the gastric acid isn't to help you digest food, it's to kill pathogens. So you took one of the baby's main pathogen defense mechanisms away by putting the baby on acid suppression. So you actually did harm for this baby, and no good, no improvement. Now, I will tell you that I don't know that this was in the paper, but Susan told me once that anytime she does a study like this, and she's done many of them, she always puts the babies on Nutramigen for 2 weeks before she enrolls them in the study. And the reason she does that is to exclude all the allergic babies. So these were non-milk allergic babies, and I think that's important as we talk a little bit more about this. So here's another study that I like, basically because it showed that, and this was done with pH studies trying to see if babies refluxed when they were crying, and there was no correlation between reflux and crying.